Good morning, good afternoon, good evening, everyone, and welcome and thank you for joining us today. My name is Mthulisi Dube. I'm a senior nutrition advisor with Action Against Hunger UK, and I'll be your facilitator for today's webinar, which is entitled Lessons Learned from Accelerated National Review and IMAM Guidelines. We're going to be focusing on three countries for this particular webinar, but the project was focusing on about seven countries. So this webinar is brought to you by the Global Nutrition Cluster in collaboration with Eleanor Crook Foundation, Action Against Hunger, and partners who participated in the review of the National IMAM Guidelines in Laos, Central African Republic, and the Republic of Tanzania. We know this is a topic of growing importance. We're excited to engage in meaningful dialogue, share insights, and hopefully spark new ideas and collaboration for the future. But before we dive in, um, here are a few quick housekeeping um, notes. So this session is being recorded and will be shared afterwards for those who would like to revisit it and those who have not been able to attend. We have French and Lao direct interpretation. So you can choose which language you would like to listen the webinar in. Um, so at the bottom of your screen, there is more, so you can click on that and choose the language. And please, as usual, please keep your microphones muted during the presentation to minimize any background noises. And if you have any questions for our speakers, feel free to drop them in the Q&A box, and we'll have a session towards the end for our question and answers. So before I can introduce our panelists and presenters, I would like to welcome Eileen, representing the Eleanor Crook Foundation, who financially supported this work, which was done through Action Against Hunger in 7 countries, to give us some opening remarks. Over to you, Ellen. If
Hello, everyone. Can you hear me?
Yes.
Okay, great. Thank you so much. My name is Ellen Yakowenko. I am the Associate Director of Research, Policy, and Scaling at the Eleanor Cook Foundation, focused squarely on our wasting portfolio. The 2023 WHO guidelines on the prevention and management of wasting and nutritional edema in children under 5 represent a significant global milestone. They are the product of over a decade of research and innovation, and they introduce key advancements such as empowering community health workers to deliver treatment, improving care for children with moderate wasting, and addressing the unique vulnerabilities of infants under 6 months of age. The real opportunity for impact of these guidelines, though, lies in how countries translate the global guidelines into something they call their own. Because updating the national guidelines isn't just about adopting what is in the global recommendations, it's about adaptation. And that's why today's discussion on the national wasting guideline updates in Tanzania, the Central African Republic, and Laos is so important. The governments, led by each of their respective ministries of health in each of these countries, have taken bold steps to shape their guideline updates into something practical for local realities in alignment with each of their health systems and in ways that meet their own community specific needs. I would be remiss at this point not to mention the elephant in the room, though, which is the timing of these guideline updates. Adaptation of the guideline updates doesn't happen in a vacuum. And we are in the amidst of a dramatic and unprecedented shift in global resources, especially for nutrition programming. So, through the lines of this discussion, I'm particularly keen to hear from our counterparts and the panelists how they're reconciling the ambition of these new guidelines with the resources, the shift in resources, and what we expect to have available over the next few years. I'm keen to hear their perspectives, but also to start brainstorming on how we as a nutrition community can be supportive of each of these countries' continued progress over the next few years so we don't see any loss in the remarkable gains that we've made over the past decade. And with that, I just want to say thank you for joining us. Thank you especially to the panelists. And I hand it back over to you. Thank you so much.
Thank you very much, Ellen, for those words and kicking us off, especially looking at what we are facing and the task that is ahead. So no pressure to the presenters today. The ball is now in your court. So let me please bear with me. I am looking. Okay, there we go. So today, I think we are very lucky to have a very diverse and distinguished group of experts who will bring a wide range of perspectives and passion to today's topic. And they are from Laos, from Central African Republic, and Tanzania. So from Laos, we have Dr. Ketkeson, as well as Dr. Ketkeson, who is the Deputy Director General of the Department of Hygiene and Health Promotion in the Ministry of Health in Laos, as well as Roderick, who is a consultant with UNICEF. Then from Tanzania, we will be having Peter Kaswahili, who is a senior nutrition officer, and then from the Central African Republic, Dr. Mbari, who is the head of nutrition and food hygiene at the department in the Ministry of Health and Population. So without further ado, I will hand over to the Lao team to kick us off in their presentation. Over to you, Roderick.
Thank you so much, Felice. I just confirm if you can hear me.
Yes.
Yes, it's clear.
Good. Thank you so much. So, on behalf of Laos, I will be co-presenting with Dr. Ket Keson, our Deputy Director from the HHP, in today's presentation. So I will do the first half of this, and then he will do the second half of our presentation. So we will be sharing our experiences in terms of our the review process and the revision of the national IMAM guidelines and the job aids in Lao PDR. Next slide, please. Sure. Please. Good. So just give you an outline of the presentation. We will be first going through what's the overview of wasting, particularly in Lao PDR. And then we will see how the process of the transition from our 2018 guidelines to the 2023 WHO guidelines, which led us to the 2025 version of our guidelines. And Dr. Ket will also be going through the review process and what local adaptation we have done with the WHO 2023 global guidelines into the context of Lao PDR. And what were the lessons that we've learned from the process, and what are the ongoing and future challenges that we are looking into right now, and what are the ways forward into this. Next slide, please. So just to give everyone a brief overview and background of our wasting and nutrition situation in Lao PDR. Currently, we are at around 10.7 prevalence in our wasting. This is a result of our LSIS-3 survey data from 2023, which has an increase of 1.7 from 2017, which was a prevalence of 9% in 2017. So if you look at the national prevalence of wasting, we are still on the high of around 11. But if you also look at on the second box, it shows also the provincial wasting prevalence, wherein it shows the blue one shows the current one, which is the LSIS-3 results, while the red one shows the 2017 prevalence wasting. If you can see the differences, there are some provinces who went down from a high rate to a lower rates, but most of our provinces really went up, especially 11, 12, and 13, which is Salavan, Savanaket, and Sekong, highlighting almost 26% in Sekong in terms of our prevalence of wasting. Next slide, please. And one of the things that we're also considering why the wasting prevalence is also rising up is also because of the infant and young child feeding situations in Lao PDR. If you look at the second bar, we only have a 50% exclusive breastfeeding, and we have less than 45%, less than 50% of our early initiation of breastfeeding among our babies here. And introduction of solid food is up to 78%, while the minimum meal frequency is at 61%. And our diversity in terms of our diet is only 40%. And acceptable diet is only 28%, with our continued breastfeeding up to 23 months is only around 37%. So this somehow contributes to the rising prevalence of our malnutrition among our children because of the diet and the way our kids are fed from birth. Next slide, please. So this is our version of our 2018 version of our national IMAM guidelines. And this was, I think the process started in 2018 and we finally have it rolled out to use at 2020. So this has been in circulation in the country and being used for different trainings across Lao PDR. So we have a national guidelines, which is the red colored on the left side. And we have our 3 job aids, which is divided into the community job aid, the dark green one. And the blue is the OPD job aid, and the lighter blue is our IPD. So the community OPD and the IPD job aids is divided into 3 because it's now given to the trained staff after they had a training using the red book, and then they will now have an easy reference of their in their jobs, so that when they are now working in the community or in the OPD or in the IPD, then they have an easy reference, which is the job aids. Next slide, please. So from this 2018 version, of course, we get to know about the 2023 WHO IMAM guidelines updates, and then we are looking into what really the global advice in terms of how to manage malnutrition across the globe. So now the government of Lao PDR ventured in reviewing and revising the national IMAM guidelines with the collaborations, of course, of UNICEF, Action Against Hunger UK, and other development partners that are also working on nutrition within the country. So from 2024, last year, around April, May, we started discussing all of this. And then up to this time, we are now in the final steps of the final draft of the guidelines, which will be presented in details more by Dr. Ket later on. Next slide, please. So in the 2023 guidelines, these are all mostly the highlights of the 2023 guideline, which is the management of wasting and nutritional edema. In our current version, the 2018 version, we only deal with 6 months to 59 months of children and infants who are wasting. But in the 2023 guidelines, it includes more or less less than 6 months of infants, which again we assess for the at risk for growth and development. So, and then we added this as a additional content into our 2018 guidelines and some other new changes and adaptations into the local context. And then we had a lot of focus on prevention of wasting and nutritional edema in our new guidelines, adapting into the 2023 global guidelines from WHO. Next slide, please. So I will hand you over to Dr. Ket to let us go through the process of what we have done since 2024 up to the current period right now. Dr. Ket?
Thank you, Roderick, for the first part of the presentations. Now I just would like to bring to the process of the IMAM development process. In 2024, we start from the quarter 1 discussions and meeting with key stakeholders to start the process of review and revisions of the IMAM guideline. Meeting between AAK, UK, and Nutrition and UNICEF was done to establish the work plan and to map out the variable resources for going through the review process. As you can see in the second quarter in the 2024 stakeholder mappings, rapid assessment, and first review of the workshop, with the leadership of the Center of Nutrition and Support from the consultants from the AHK and the UNICEF, and rapid assessment had been done, and then we moved to the quarter 3 in 2024 to review process and workshop of the National IMAM guideline. During this quarter 2 of 2024, the first workshop was also done and the steering committee was created, where the results of the rapid assessment was presented, and the proposed plan for the review process was also shared with the committee. At the same time, the technical working group was set up to start the review and revision process. The technical working group was composed of experts in the clinical and community services for malnutrition. So from quarter 2 and quarter 3, the review process continued with several consultations within the technical working group and other experts in Lao, PDR, and globally. In quarter 3, other reviews workshop was conducted to present the revised versions of the IMAM guideline and job aid. The different flow diagram and order changes in the guideline was presented to consult within the technical working group for any change needed, and to ensure the alignment of the revised guideline with the existing clinical guideline in Lao PDR. In quarter 4 in 2024, the draft was sent through the graphic designer, ensuring on the flow diagram are well done in terms of layout, and on the other layout work are done. While this is being done, the training of master trainer was conducted in February 2025. Both IMAM, IPD, and OPD, the test of the contents the revise of the guideline and job aid. At the same time, create the revised training packet for the trainings program. During the same quarter, the contents of the revised IMAM guideline has been validated by the Ministry of Health through the stakeholder meeting done in March 2025. In quarter 2, this is the end of the process of the revisions of the IMAM guideline. In this period was sent to finalizing on the layout and designs of the guideline and job aid. So it will be ready for the final presentations and approval by the Ministry of Health by this week, hopefully, but we submit the approval and information letter to the Minister of Health. That is the process of the IMAM guideline and revisions process. Next slide, please. Due to the high incidence of beriberi in Lao PDR, the national IMM guidelines include the administrations of vitamin B1 thiamine, because of a lot of thiamine deficiency cases has been found in Lao PDR in mothers during ANC and in young infants less than 6 months. So this is very important to add into the new revisions IMM guideline. Next slide, please. So what we have learned from this revision process, so continuing attending the IMM revisions guideline, especially for those who have experience. So this process is the key success of the review process and ensure the quality of the contents. And we also found that regular consultation with expert and key stakeholders is important to ensure the quality of the review process. And mapping out the current services for malnutrition is also important to ensure local contextualizations of the final outcome of the revisions. So also the community engagement and awareness of district local public health concern will all ensure local adaptations of the new guideline, for example, the thiamine deficiency. And the last one, we also found that translations from the English version to the local language like Laotians, it a little bit take time on that. But finally, we have it in our hands. So next slide, please. This is the IMM guideline and job aid that we have been finalized. So we have the management of the IMM. This is a national guideline. And we also IMM for village health volunteer or community, OPD, IMM OPD, and IMM IPD, and job aid also. So next slide, please. So we are grateful for the support from Eleanor Cook Foundations for the review and revisions of the national IMM guideline, but we will need further support ensuring and the rollout and use of the revised guidelines. So will be efficient, and that the national IMM program will be an effective tool to preventing and treating malnutrition in Lao PDR. So the Ministry of Health remain committed in the implementations of the program, but we will need to continue support and collaboration intervention of our development partner in these implementations. So ongoing future challenges as I show in these slides. So if we now move to the next slide, please. So what we are going to do next, we are going to roll out the IMM guideline and job aid we have approved. So over the country. So hopefully we can get printed hard copy and introduce and roll out over the country. So keep reviewing the contents and contextualize as implemented. We can get more input, what we have learned from the local community and from various settings, and align on training packages with the revised IMM guideline and ensuring the alignment of other national guidelines in Laos also. So interministerial implementations of the nutrition program is very important. But we see that multi-sectoral collaboration will improve these nutrition. So we initiate interministerial working relationship to curb the burden of malnutrition in the country. Ministry of Agriculture, Ministry of Education and Sport, Ministry of Social Welfare, and Ministry of Public Work. So, and highway to ensure national specific nutrition related interventions will align and complementary of each other. So Lao government to continue to take lead and bring all the development partner together for a common goal to prevent and treat malnutrition. So that is my last slide. Yeah, also there's collective and collaborative interventions in Lao PDR also, our next plan also. So next slide, please. So That is my last slide. Thank you very much, and over to the moderators. Thank you.
Thank you very much, Dr. Kat and Roderick, for the presentation, detailed presentation on how you were able to lead the revision of the IMAM guidelines in Laos, and what you are planning to do to make sure that you roll out these guidelines, so that we do not waste a lot of time. I would like to call upon our next presenter, who is going to be from who is going to be from the Central African Republic. That is Dr. Mbari, to make the next presentation. So just a reminder to everyone, if you'd like to ask any questions to our panel or our presenters, please put the questions in the Q&A box. My colleague will be going through those questions and will be putting them to the panel at the end of the presentations. Thank you very much. So over to Dr. Mbari.
Bonjour tout le monde.
Hello, everyone. Hello, everyone.
ค่ะ
First of all, I want to say thank you to Global Cluster to have given us this opportunity to present what's been done in the country. And the Central African Republic has nearly finished the process, because in the month of March, the document was validated technically by the technicians and validated by the Minister of Health. Now we'll go directly to the part that is interesting us. So it was really to present the lesson learned from the work that we've carried out. I have to say, the country chose an approach inclusive and participative. We have included all the stakeholders from the planning stage and the different sectorial ministries that have an influence on nutrition, and that carry out activities specific to nutrition, but also activities that are sensitive to nutrition. There was also NGOs, agents of the United Nations system, also civil society, and also lessons. We used analysis tools so as to have the pertinent for mapping. We wanted mapping on the territory. We used prioritization metrics and systematic decision making, so that we had an objective identification of the key actors and their role in the whole process. And we favored as well transparency in the decision making. Decision making was always collective, so that there is no one party that is frustrated. So we have a clear plan with clear milestones to maintain the engagement of partners, have continuous follow-up, and that and so that the terms are also followed. We have reinforced national structural capacities in terms of management of project to ensure multi-sectorial coordinations with technical leadership, so as to make sure that we own the process and that it's sustainable. And all this was documented so that we have a process that is documented for each technical component. So we wanted national experiences and also data that we could trust, and we were able to have discussions that were in general agreement when we had working groups. We've installed, put into place a clear technical and political validation mechanism. And we have, of course, we wanted a lot of expertise from the field, because a lot of our partners were coming from the field, working in the field. And also we confronted them with scientific recommendations from the WHO and also the University of Banki. And at the end, we wanted a ministerial decision that was made. That was the plan. In terms of operational strategy and pragmatic strategy, we capitalized the structures that already existed. Mobilization of a community relay, mayors and health agents that already exist in the country. So that allowed us to reduce the costs when we used human resources, community human resources that are already had training. So of course that reduced the cost, and we targeted the cases that are most at risks. It was a priority targeting PAM that is helping us with moderate and acute malnutrition. They don't go everywhere in the country. They go in the zones of the country where I have malnutrition that is acute, moderate, and very high. So we have 11 districts out of the 35 in the country. So we spoke together so as to see where we could give priority to children that were giving moderate to acute malnutrition, and only so that we could do all over in the country. We only targeted them that presented risks. We also integrated nutritional activities in normal services, like, for example, intended vaccination programs, prenatal consultations, follow-up for growth. That's services that are linked with nutrition. The key messages, that to do with alimentation with young children, but also WASH. It's as soon as the child is integrated in when he's taken care of, and to reinforce the impact of care that is given with few resources, so as to be able to prevent malnutrition, but also messages for nutrition and education that are known in all the services that I've just mentioned. Also, we supported an alternative logistics and a reinforced coordination. And I want to say, to research for local solutions, to try to buy local mutualization of the partners, and also follow-up of stock in real time, and to adjust the flux. So at the moment we're using VHS2, and we asked, so this tool, we wanted that the management input would be notified through DHS2, so that at the level of district, but at the central level, so that the follow-up of stock was being done live in real time. So we tried to answer part 3, but also part 5 of what we are being asked. And I do thank you very much indeed.
Thank you very much, Dr. Mbari, for sharing the experiences from Central African Republic. As I had said at the beginning of our webinar, Central African Republic is amongst the 7 countries which Action Against Hunger, with the support from Eleanor Kroc Foundation, was supporting in the update of their national IMAM guidelines. And what they have just shared is their experiences and some of the key lessons that have emerged from the overall review process. just a reminder again to put the questions in the Q&A box. I think in the interests of time, I would like to move on to the presentation from Tanzania. So we have Peter Kaswahili from Tanzania, who will be giving us their experiences in the review process, as well as they're going to be going into a bit of detail that and looking at specific recommendations that they have adapted and contextualized to the Tanzanian context, and explaining and going into a bit of detail what influenced the decisions and why they prioritized particular recommendations in their national guidelines. So, Peter Kaswahili, over to you.
Hello, good afternoon, everyone. My name is Peter Kaswahili. I'm a senior nutritionist working with the Ministry of Health. I'll be actually, before jumping to what we have adopted as a country, I would like to acknowledge the composition of our technical advisory committee. Our committee was composed of representatives from UNICEF, we had a representative from WHO, we had a representative from WFP, we had a representative from IRS, we had a representative from Red Cross, we had a representative from World Vision, we had a representative from Ministry of Health, Ministry of President Office and the local government. We had a representative from Tanzania Food and Nutrition Center. We had a representative from nutrition officers, regional nutrition officers, and we had a representative from counseling nutrition officers. We also had a representative from region zone hospitals like Muhimbili, Dodoma, and Singida. We had a representative from research organization like Ifakara. We had a representative from academia, University of Dodoma and Muhimbili. So it was inclusive in the sense that we wanted to bring experiences from every part which deals with the management of wasting in our country. Therefore, let me jump direct to what we have adopted as a country, and our focus will be based on a different age category. The first one is management of infant less than 6 months of age at risk of poor growth and development. Therefore, we have adopted the following recommendation, which is infant less than 6 months of age at risk of poor growth and development who have any of the following characteristics should be referred and admitted for inpatient care. The characteristics are as follows: one or more with an IMCI danger sign, acute medical problem or condition and severe classification as per IMCI guideline, medical problem that do not need immediate inpatient care but need further examination and investigation, like HIV-related complication, medical problem needing mid or long-term follow-up care and with significant association with nutritional status, for example, HIV, TB, or other physical disabilities, ineffective breastfeeding or feeding concern for non-breastfeed infant, breastfeed milk substitute for replacement feeding or milk refusal, specific anthropometric criteria from the list of criteria, just as they appear on the board. Next, please. Still on the same category of children, we have also adopted the W recommendation or good practice, which reads as follows. Infant less than 6 months of age at risk of poor growth and development who are admitted for inpatient care can be transferred to outpatient care. Another recommendation which we have adopted is infants who are less than 6 months of age with severe wasting or nutritional edema who are admitted for inpatient care should be breastfed where possible, and the mother of female caregiver should be supported to breastfeed the infant. Another category of age is management of infant and children 6 to 59 months with wasting or nutritional edema. So the following recommendation have been adopted. One is infant and children 6 to 9 months old severe wasting or nutritional edema who have any of the following characteristics should be referred and admitted to inpatient care. One is IMCI danger sign, acute medical problems, severe nutritional edema, and a poor appetite, like failed the appetite test. Another one is infant and children 6 to 59 months with severe wasting or nutritional edema who are admitted to patient care can be transferred to outpatient care if they do not have any danger sign for at least 24 to 48 hours prior to transfer time.
Sorry, if I can just interrupt. Can we have the slides advance? We are not seeing them move forward. Thank you.
Can I ask the organizers to share the slide so that people can see, everyone can see?
Yeah, sorry, just give me a minute. I'm trying to get the slides. Yeah, I think we should be good to go.
I think this one is the old version.
Dube, go to recommendation B. I think he was already on the recommendation B. Next slide. Next slide.
Next slide, please. Yes. So I was here. Yeah, I was on B3. Another recommendation which we have adopted is the infant and children 6 to back up, please. I will be repeating if I present on this slide. Okay, let me proceed. Yeah. Yeah, okay. Can I proceed, please? So another recommendation is the infant and the children 6 to 59 months with severe wasting or nutrition edema or admitted to inpatient care can be transferred to outpatient care. They do not have. Yes, we have adopted this recommendation as well because it is in line with our setting. Another recommendation with regard to management of infant and the children 6 to 59 months with wasting or nutritional edema is infant and the children 60 to 59 months of age with severe or nutritional edema who are dehydrated but are not in shock. The preferred rehydration fluid is the rehydration solution for malnourished children, Lysoma. If not available, low osmolarity oral rehydration solution can be used. And the low osmolarity ORS is already available in our setting in comparison to the Lysoma, hence it is feasible in our context. Another recommendation which we have adopted is the infant and the children 6 to 59 months of age with severe wasting and or nutritional edema who are enrolled in outpatient care, ready to use therapeutic food. RUTF should be given in a quantity that will provide Roman 150 to 185 kilocalories per kilogram weight per day until anthropometric recovery and the resolution of nutritional edema, or 150 to 185 kilocalories per kilogram per day until the child is no longer severely wasted and does not have nutritional edema. Then the quantity can be reduced to 100 to 130 kilocalories per kilogram per day until anthropometric recovery. Yes, we have adopted this recommendation, but not for children with nutritional edema. All children with nutritional edema should be provided with inpatient therapeutic care. Rationally, based on the estimated energy need and the target weight gain of 5 to 10 gram per kilogram per day, an intake of 158 to 183 kilocalories per kilogram per day has proven sufficient. This revised range not only support recovery but also optimize the availability of RTF, helping to stretch resources and reach more children in need. Next slide, please. Another recommendation which we have adopted is management of infant and children 6 to 59 months with wasting and or nutritional edema. The recommendation is assessment, classification, and management of referral infant of children 6 to 59 months of age with wasting or nutritional edema be carried out by community health workers as long as they receive adequate training and regular supervision of their work is built into service delivery. Yes, we have adopted this recommendation and it aligns with the national community-based health program post taking ZW with screening and follow-up of activities in the community. Next slide, please. Another recommendation which we have adopted is in context where wasting and nutritional edema occur, multiple micronutrient powders should not be given to infant and children 60 to 23 months of age for specific purpose of preventing wasting and nutritional edema. Yes, we have adopted this recommendation, but we know for sure that MNP address iron deficiency and iron deficiency anemia and are recommended for infant and children in Tanzania where the burden of anemia and malaria is still high. MNP are not effective in preventing wasting and nutritional edema, and in our context should be reserved for addressing the burden of anemia. Next, please. Regarding with the adoption, I think we end up there. Now there was a question on strategies to roll out the guideline in financial constraint. I think this question should be answered by everyone, but to our setting, we have come out with different strategies. The first one, we know that the government remain committed to delivering essential health services, including nutrition services as a national priority. Second, we shall leverage ongoing health and nutrition program program, the updated guidance will strengthen, will be integrated into service delivery system, sustainability and cost efficiency. Also, Ministry of Waste will roll out training in phases, starting with the high burden region to allow manageable scale up within available resources. Also, we shall leverage on job training, supportive supervision, and mentorship to build capacity. Next slide, please. Okay, we shall foster nutrition partners to align existing resources and intervention in rolling out the updated guideline. Ministry of Health, collaboration with the PRH, will ensure each public health facilities budget for guideline implementation, because right now the funds are allocated directly to health facilities, not to the council as it used to be. Also, we shall share capacity assessment and the health system readiness mapping findings with the key nutrition partners and the LGs for operationalization. And the last one is we shall propose the updated guideline to implementing partners and development partners for support. Next one, please. And this is the end of our presentation. Thank you very much for your patience.
Thank you very much, Peter, for that presentation on the adaptations I think that were made in Tanzania. I know that there are a number of questions, and we would like to ask our presenters and our panel. Now, I think I would like to open up to those questions. So I think my colleague who was going through the Q&A box, please share any questions that are there for our presenters.
Yeah, the first question is related to the prevention. Okay, couldn't the prevention of malnutrition already begin with pregnant women? So there was an answer given, but if you have further to explain that.
Do you expect me to answer more? Or
Yes, probably if you can just,
yeah, definitely. I think the new revised guidelines for Lao PDR especially, we are now just focusing not just on the 6 months to 59 months children, but we are now focusing on less than 6 months plus the pregnant mother. So we start the intervention for prevention from the mother when the mother conceived the baby. So the prevention of malnutrition starts from when the mother conceives the baby and when she's pregnant. So it's already included.
Yeah, the person who asked this question, if you have further question following this response, please feel free to raise your hand and pose your question. The second, okay. Please go ahead.
Once again, I would like to thank to the Illinois Cook and also the UNICEF country representative and the colleagues who provide a very good support during the revisions of IMAM guideline in Lao PDR. So we have responses to some questions by Roderick, but I just want to add more something that we need to work more on the IMAM screening in the community. This is our priority. And to develop IMAM tracker is crucial for us. We want to get data collections, reliable data from the community and information from the remote area. And I think that is the way forward for us. And our next effort for the IMAM guideline rolled out in our country is try to implementation and integrated to other services at the community level, for example, in the health center, and also the quality of IMAM services and treatments. And we have to work on that also with the Department of Healthcare and Rehabilitations. And also we think that we have a possibility to involve more development partner, and also getting more increase more domestic funds and integrate IMAM in primary healthcare, for example. But I pose a questions in the comment box to a friend and colleagues from African country. Do you have, this is my questions, do you have any experience or lesson learned from integrations of IMAM in the primary healthcare workforce in your country? If you have, please share. So thank you. Over.
Okay, thank you so much. Then the next question is there any update on how to manage IMAM clinical data at the health facility level or community level? So I see Roderick tried to reply.
Yes, I already replied to this in the Q&A. But again, just to reiterate, in our IMAM guidelines, the reporting and recording section of the training is also included in the guidelines. So everyone that we train in the training program for either IMAM IPD, OPD, or community, the recording and reporting system of the country is also being explained, and they are being trained on how to use the different tools that we use, both paper-based and online-based reporting system. As already mentioned by Dr. Kat earlier, we have this what we call the IMAM tracker, which is another way of reporting individually our children identified as SAM, alongside other reporting systems in the database that we have for the country, which is the DHIS2 system. And so we also collect data from the villages to the health center district to the province up to the central level. And of course, there's still a room for improvements for all of this, because sometimes we don't get the data on time, or the accuracy of the data is also something that we need to improve. And the other thing on data is also how data is used and analyzed to inform us in terms of our ongoing program planning and the way we, how would I say, tailor fit our program based on the data that we receive from all health facilities across the country. So it's being integrated into the whole IMAM programming, if that makes sense.
Okay, thank you, Roderick. Then the third question is, the review process took almost a year. How did you monitor your progress? What adjustments have you made in your work plan? And together with that, what other national guidelines and policies would be affected by the changes or updates made to the national IMAM guideline? And what is the role of the academia in this review process?
Okay, there's a lot of questions. But anyway, start with the first one. The review process took a year. We were hoping to do it within a few months, like 8 to 10 months. But again, as mentioned in our challenges, particularly for Lao PDR, the translation from English to Lao, Lao to English, and vice versa really took a lot of time. So we have to adjust all our work plans in terms of like the progress we are making along the way of the revision and review process. And then in terms of our multi-sectoral approach, we tried to, as I said, engage, as what Dr. Ket again mentioned in his presentation earlier, is that the interministerial approach right now, this is what we're trying to achieve, that now we have the revised guidelines. We're trying to see how the Ministry of Agriculture, Food Security, the Ministry of Education and Sports, the Ministry of Social Welfare, all of this should be involved in the way nutrition programming can be done in across of Lao PDR, so that nutrition is not just going to be a health problem for the Ministry of Health, but it's going to be a topic for every minister that is involved and can affect any nutrition-related programming. And the way our national guidelines are now being done, we are now also making, again, the policies are also integrated and changing, and we tried to also engage with the academia. I mean, actually the National University of Laos, the College of Health Sciences, I would say, University of Health Science, and the Lao Pediatric Association is also in charge of the academia, is also involved in the whole process. That's why we said that we have to align all our national IMAM guidelines with the existing clinical guidelines for pediatrics, for example, or other discipline in the country, so that everything speaks to each other and align, and it's not confusing our health workers. I think Dr. Ket would like to add something. He raises hand. Dr. Ket.
Okay, go ahead, sir.
Yeah, thank you. I think we go on the right way because couple years ago, nutrition, especially IMAM and SAM in Lao PDR, had been raised as a national priority. And this is a national agenda which is shared by the Deputy Prime Minister with the four-line ministry, with the aiming of the multi-sectoral collaborations include Ministry of Health, Ministry of Education and Sport, Ministry of Agriculture, and Ministry of Planning and Investment. So we have to now, like Roderick mentioned, that we have to analyze the policy, because these different line ministry, they have their own priority. But the main that we are going to work together to minimize the malnutrition, especially SAM and IMAM, that we have at the moment, which is a very high rate among the rural community in Lao PDR. So, and in addition, that we want to move more and work more on that is pre-service educations. The revised versions, the revised IMAM guideline will be teachings in the medical college and also University of Health Sciences, and have been rolled out, planned to roll out over the country. So that is one thing that we will see how can we integrate it into other training curriculum, for example, Faculty of Agriculture and Forestry in the National University. And also, I think the multi-sectoral collaborations inform us that we need to extend our opportunity after the COVID-19. And this approach we continue using IMAM as before the window of opportunity cross. And one thing that we will have is that IMAM guideline is our work outcome and touchable outcome to show the government commitment. So I think we are going to integrate it in the primary healthcare workforce in Lao PDR to increase local community engagement, to increase ownership and leadership in terms of scaling up nutrition in the community. So over, thank you.
Thank you. Dr. Ezekiel, I see your response. Would you like to speak about it? Okay, if not, any additional comment from colleagues in Tanzania or Central African Republic on the same question?
Excuse me.
Yes, please.
I think there is a good questions in the questions and answer
Yeah.
box. What is the cost of implications for national IMAM guideline reviews and other main activity requiring the cost? That is quite difficult. So thank you. If anybody can give
Sure.
comments on that.
Colleagues from Tanzania or Central African Republic.
Yeah.
Okay, go ahead.
So, yeah, this is Mr. Kaswahili from Mr. Kaswahili from Tanzania. For us, I think this process has taken more than almost a year, and we are brainstorming. The cost is around 95,000 million US dollars. 95,000 US dollars, and leaving away the printing process. So it is a bit expensive. Thank you.
Okay, patient. Mr. Bakid.
Yes, to answer your question regarding the duration of a process, we had 18 months. Originally, it was 12 months, but we
เวลาอยู่
went
ประมาณ
over to reach
12
18
เดือน
months, but it was really due only to the different calendar that didn't match, and also the difficulty of being able to gather all the key actors when we were in need. So that's why it took us, we took 6 more months. Now, for the cost, I don't have the documents with me regarding the cost. I'm going to look, and maybe I can come back to you regarding the amount. But because I'm taking the floor, I wanted to ask a question that I asked also to the colleagues, to my colleagues of Laos, is that in that context where resources are diminishing, are reducing, the country, our country will have difficulties in the, in the supply chains for aliments that are ready to use food. So what's your experience? So what did you recommend? Because I'm sure that the context and dwindling resources and cost, we're all in the same situation. I'm sure you are as well. So that's the question that the Central African Republic want to ask to the Laos colleagues.
Okay, thank you. Then another question. Thank you, Peter from Tanzania, for your detailed presentation. Can you please share more how the country plans to roll out management of wasting and nutritional edema by community health workers? For example, are these health cadres paid a salary? Will they be supplied with RUTF or SSF for IMAM supplementation? And the necessary equipment plus routine medications needed to manage children with wasting and nutritional edema. So, Peter.
Yes, thank you so much, Doctor. Currently, we are actually switching to the approach whereby community health workers are trained for 6 months in the training college, and these people are expected actually to do some of the active treatment activities and the prevention activities at the community level. Now, regarding the wasting management, we haven't started yet because we have only one batch of CHW in the community, but we are hoping to go there, whereby they will be equipped with the tools like Muaki tools, height boards, and the weighing scale in order to identify early children with the wasting issues and to refer them to the facilities level. But as we speak, we haven't actually started. We are managing wasting from the facilities which are health centers and hospitals. Thank you.
Okay. Then the next question is, an operational guidelines of the WHO guideline will be launched soon. Will you consider this document to revise again your detailed plans, your guidelines when the document will be launched?
Yeah, in fact, we are expecting to launch the guideline in the end of July, and we expect to bring every party on board to see how we can actually participate fully in sourcing out resources in order to ensure that we make use of the guideline, because launching is another thing, and operationalizing the guideline is also another thing. But we are trying to sensitize every key partner to see the role which we play after the guideline has been launched. So we are optimistic that we shall set out some resources to ensure that the guideline become operational, particularly in our communities, not only in this facility, but also in the communities. Thank you.
Thank you. Any additional comment from colleagues Lao or Central African Republic on the same question? Okay. The next question is from Everlyn. Several countries have chosen to test or pilot new recommendations for various reasons, such as to assessing resource needs and the practicality of implementation. How did your country evaluate resource requirements and implementation feasibility?
Hi, I can answer
Please.
this partly. In terms of ensuring that our country is able to, provide the resource requirements, especially for the implementation feasibility. At the beginning of the process, we did some rapid assessments, and then we also did some, how would I say, consultations among different stakeholders, and we, how would I say, with the support of our consultants from Action Against Hunger UK, Diana and Yara was also into like interviewing some key people who are already delivering services and seeing if we will be introducing such kind of innovations or new things in the new revised guidelines. What's the feasibility of this? So we were like doing a, how would I say, a what if scenario wherein like if we will be doing this, what will be the resource requirements? What's the feasibility of doing this? Especially right now with the revised guidelines, it will, with the addition of like under 6 months infants being assessed for poor growth and development, it will increase our, how would I say, admissions or admissions into the program for IMAM, for example, and that would mean more patients. Would our facility be able to handle such influx of more patients? So we have been asking different hospitals, health facilities, and see, what would they say about this? Would they be ready to accept more patients? Would they be ready to care for more patients, even if they are not yet malnourished, but they're at risk for poor growth and development? Then that would mean an increased workload for them, needing more staff, needing more equipment, for example, or needing more supplies for treatment, for example. So there has been a lot of discussions on that, and there have been lots of consultations as well. So that's why we're trying to be, how would I say, careful in terms of like what we put in the guidelines, because what's in the guidelines then once approved by the Ministry of Health, then we have to implement this, and we have to make sure that our health facility, which is again, of course, managed by Ministry of Health, are ready to accept this increase of workload, this increase of patient influx, this increase of things to be done and things of activities that will be done by our health workers in terms of nutrition. So there are been, I would say, informal feasibility studies, I would say. It was not done as a study per se, but it was done more of a consultative feasibility studies. That makes sense.
Thank you. Thank you, Roderick. Any feedback from Tanzania? I know we have done some feasibility studies, even competency assessment. So would you like to talk about that, Daudi, or anyone from Tanzania, Team Tanzania?
Yeah, thank you, Dr. And the rest of the panelists. Let me allow me to jump in on behalf of the TAC chair. Actually, on the feasibility study we did before the kickoff of the assessment of the review process, we were able to do a desk review on checking the readiness, what is existing, and what is the local context that can be adopted or adapted. And the ministry was also on the driving seat to gather all the gaps and opportunities that we can leverage on this review guide, the review process. So the last area that the government already has invested on it, and for instance, on the supply commodities, there is an ongoing process through the Ministry of Health and TFNC in developing a local product for the management of wasting, and it's almost on the final stage. And we are looking forward, maybe in this financial year, some of the will be actionized, and we'll be having a local product on that. So it reached a level on checking the yes. And again, regarding the staffing, the Ministry of Health, of course, in collaboration with the President Office that coordinate all intervention and the local authority, are also in plan, especially through this financial year, to ensure that how are we going to cascade the training manual, because the new development on the guidelines, it is just an addition of the 2018. And on your first question that you asked, that the WHO is in the process to launch a new operational strategy, if we can maybe going back again to review, not really, because when we started the review process, we included all the required changes. That's why when Mr. Kaswahili was presenting, the representation was very, very comprehensive from the primary level to the national level health facilities. So we don't see there will be a major change, and if it be, we'll see through our normal routine on how to update, if it will be really much required. That it is from the discussion that we were having during the technical advisory committee. Thank you, Dr. Ari, over to you.
Thank you, Daudi. Any feedback from Central African Republic on the same question? If not, the next question is related to outpatient management of wasting. Most of the time it is faced with challenge due to lack or limited availability of RETF, SF, and resource limited settings. How is this challenge accommodated in the new guideline, or what are the experiences in dealing with such challenges? Basically, how do you account as you roll out this guideline? How do you try to address the possibilities of like shortage of supplies? Any feedback? Team Lao or Tanzania?
Hi, can you hear me?
Please.
Yeah, think it's an ongoing, I would say, a long-term challenge in terms of availability and sustainability in terms of stocks of RUTF and RUSF in Laos particularly. I don't know with other countries, but in Laos, we're really struggling with our supply of RUTF. So that's why we're trying to make good use of our little stocks that we have for the rest of the country. So we are making sure that every sachet of RUTF goes to the health facilities where they need it, and it's given to children that needs it. So we're trying to avoid the use RUTF in mom kids. We're morely using it for some children in our context. And right now we're also working on a different project in terms of local supply of RUTF. So we're working right now with another partner and a local, how would I say, local factory here in Laos right now to produce locally produced RUTF made from local ingredients in Laos. And for two reasons. One reason is since it's made of ingredients from Laos, the taste of it would be more close to the taste buds of our children because it's locally produced. Second, of course, is it's economic reason wherein if it's locally produced from local products, then it would be less expensive compared to an imported RUTF sachets. But this is still in the pipeline, so we just have done our acceptability trial last year, around September last year. So we're still disseminating the results of this, and we will still be doing an efficiency study for this and ensuring that this is safe and good for the kids, and it will also have the same efficiency as what we are using right now as an RUTF for the country. So if this will prove to be a good project to be done, then we will see how we can roll this out as a project by the government for the rest of Laos to address the needs of our limited stocks and sustainability of stocks for our RUTF and RUSF. Thank you. Over.
Thank you so much. I see hands. Elizabeth, please go ahead.
Okay, thank you. I just want to compliment what Tano has talked regarding the feasibility study and now the products. We have some studies which we have tried to develop locally, product at Tanzania, and they've been tested. So we are now in the process of how are we going to roll out to the community? So we are finding a model, a good model that will be cheap and accessible for all. But most of these products have targeted the prevention and treatment of mom. So we have some sort kind of efforts, but again, finding possibility of producing the RHF at our country. So those are the things in place. We are trying to overcome the issue of shortage of supplies. Thank you.
Thank you, Elizabeth. Fimason. Yeah, please unmute your mic. Fimason, if you are speaking, we are not hearing you. Okay. Then the other question is, thank you for your insightful presentation. So this is a question for all. One, encounter any form of pushback either from the government, state, local, or the communities? So can you tell us any challenges that you have faced during the review process? Second is any encounter with the shortage in treatment supplies. And the third is to Lao PDR colleagues, what were the reasons for the 45% early initiation of breastfeeding? Okay, so let's start with the question to Lao. I see, Roderick, you have answered that question, but if you can just explain it.
Sure. I think, I'm not very particularly sure about the reasons of the 45% early initiation of breastfeeding among mothers. But again, the breastfeeding practices in the whole country of Laos is still, if you look at our exclusive breastfeeding, we're still on the 50% exclusive breastfeeding for the first 6 months. So in general, I think the breastfeeding practices in Laos still needs a lot of pushing and improving in terms of how do we ensure that all mothers are breastfeeding their kids. So we are also, again, parallelly implementing our breastfeeding program alongside this IMAM program, wherein we're trying to train a lots of breastfeeding advocates in the country. So we have trained already 4 cohorts of them, and we have around 87 health workers across all health facilities in Laos who are now working on terms of like improving breastfeeding practices of mothers delivering babies in health facilities, but including also in villages, and seeing that, you know, breastfeeding could something that we really wanted to push that mothers have to be doing. And we are planning to do more interventions for this. We're in fact scheduling some more activities for this in terms of like how do we ensure that the ENC and the KMC programs also in terms of like the, you know, in terms of newborn and mothers are being also emphasized in our programming. I think Dr. Ket also would like to add into this. Dr. Ket.
Yeah, thank you, Roderick. That is quite difficult to say that what is the contributing factor that to low exclusive breastfeeding in Lao PDR. So we need more research on that, but some kind of cultural practices and harmful practices that we have observed during our connects supportive supervisions in the rural community and especially among ethnic group. So many maternity women leave their baby 1 or 2 days or 3 days after giving birth to their mothers or mother-in-law, and they have to rush to the cultivating lands. So that is a majority of the observation from the field that we found during the community engagements. And this create a lot of infant mortality in some districts and provinces in Lao PDR. So another cultural practices and belief is that the breast of the women should be kept for husband only, not for the baby, to some extent to our observations. So this kind of practices, we have a lot of concern, and then we develop a proposal for more interventions in the very low breastfeeding. And we don't have a concrete data from LCIS also, Laos Social Indicator Survey on that, but we found that rural and urban community have different proportions on the breastfeeding, exclusive breastfeeding, really. So I'm really want to know more about that. So that is my comments.
Thank you so much. Really appreciate. Over to you, Tulsi.
Okay, thank you very much, Adunia, for facilitating that session. But in the interest of time, I think I would like to cut that session short and end the webinar here. I would like to thank our presenters for taking their time to prepare their presentations, as well as taking their time to answer some of the questions that were from our participants. When we set up this webinar, we wanted to share what went well during the review process in the 3 countries, as well as what were our challenges, as well as we wanted this webinar to be able to advise other countries that are either currently working on revising or reviewing their national guidelines, or they are actually doing it as we speak. And hopefully this webinar was very helpful to you. Just to reiterate that the slides and the recordings will be shared after this webinar. So thank you very much for joining us during this webinar. And goodbye.